It's my pleasure to introduce our plenary speaker for this session, Dr. David Rizzo. Dr. Rizzo is a professor and chair of the Department of Plant Pathology at the University of California, Davis. His research is mainly focused on fungal diseases of trees and forests. He teaches a number of courses in the Global Disease Biology undergrad program with a strong One Health focus. I will now turn it over to Dr. Rizzo.
Thank you very much, Sally. It's great to be here. I'd say good morning because it really is morning here. You can see how dark it is out here, but I'm really excited. My goal today is to kind of look at plant health as part of One Health, and it was great to log in, and the first poster that I saw was on plants, so that was quite exciting. It's somewhat of a timely time to really look at plant health, because I don't know how many people are aware of that. 2020 is considered the International Year of Plant Health and declared by the United Nations. And so I'd actually like to start off by showing a video from the United Nations about the International Year of Plant Health, because I think it really summarizes a lot of the things that I'm going to talk about today.
I am life. I am...
Whoop. Sorry about that.
I am life. I am home to millions, and I sustain millions more. My abundance brings prosperity, while my scarcity can be deadly. I cover much of the earth, and my influence extends far beyond. I have been around for longer than you can imagine, but my world is threatened. People need to take notice and do more to secure my future, because I am worth protecting. Your health relies on my health. Your life relies on mine. I am plants. I am life.
It's been great to see over the last few years that plants are being put into some of the definitions of One Health. We see a definition here from the One Health Commission from the CDC. But often when you look at how One Health is presented, this idea of a transdisciplinary, multisectoral approach of looking at human health, animal health, and the environment, kind of embedded in all of these disciplines. In general, plant health tends to be put into here in environmental health rather than considering a health on its own. And I actually really like this paper here, even though they didn't put plants in their diagram. And this is apart from their conclusions, where they say the issue of plant health as a full component of One Health concept is a challenge to be urgently resolved. In fact, human health and animal health are directly or indirectly dependent on plant health. And they continue and finish up that section with raising the concept of One Health to a realization requires also access to good plant health through productive and sustainable agriculture. I could probably spend an entire 45, 50 minutes, entire course on why plants are important. These are some of the talking points that the FAO put out as part of the International Year of Plant Health. I just want to kind of just give an overview. I mean, one of the most important ones is plants make up the majority of the food that we eat, either directly or indirectly through animals eating plants, and then we consume animals. In many low middle income countries, agriculture, particularly plant agriculture, is still a really major part of the economy. But we still lose many, many plants to various things, and that's what I'm going to be talking about primarily today, including the threats of climate change as we move forward. These are the top agricultural crops as of right now. You can see 6 crops make up the vast majority, over 60% of the crops grown, but there are hundreds and hundreds of different crops, many of which are incredibly important in a local sense. I think this figure really gives a good sense of the impact of plant agriculture. The green areas are areas where plants are grown for primarily human consumption. The purple areas are where plants are primarily grown for feed, animal consumption, or fuels. And in particular, you saw in that previous slide how sugarcane is the #1 crop in the world from total amount grown. A lot of that is used for fuels. I don't want to forget about other types of plant communities either. In that video, they talked about that plants are home to millions. So we think of wildlife, but we also can think of people. This is just a picture of the different forest communities, but we can't forget about grasslands and shrublands that are incredibly important to both people and animals around the world. So how does plant health fit into One Health? And there's a lot of different ways we can go with this. These are 4 key areas that many other people who've written about plant health as One Health have focused on. We can think of food and feed security, the availability of food to people and animals at the right place and the right time. Food and feed safety, and I think our next panel is going to talk quite a bit about this. So healthy food. Again, many people around the world depend on plant agriculture for their livelihoods. And I don't want to forget about ecosystem health. I'm not going to really focus much on that today, although this is actually what I tend to do my personal research on. I think many people have an understanding of forest degradation and how that ties to zoonotic disease and emergence of many other types of diseases. But I'm mostly going to focus on these first 3, and these are not necessarily mutually exclusive. So this is the sort of the production of some of those top 5 staple crops around the world. But if we look, we can see on an annual basis, a significant part of the crop production is lost. We're seeing most of these, with the exception of potatoes, on a worldwide basis, 20% or more of the crop is lost each year. And this can vary across the world. For example, in parts of India, we see yield losses typically over 40% for staple crops such as rice and maize. Same thing with sub-Saharan Africa. But even in a high-income country like the United States and Canada, we still see significant losses in some crops, approaching or even going over 20%. There are lots of reasons for crop losses. We have biotic agents, pathogens, animals, including insects and nematodes, weeds and parasitic plants, and of course abiotic issues, many of which are being exacerbated by climate change. I could talk on all of these for a long time. We're going to focus mostly on pathogens today. One more thing to really put this in context. There's not a lot of good recent data on the cost of losses for diseases, insects, weeds. So this goes back quite a few years, but suffice to say, it is still really important. And I think when you look here, so the actual crop production was 950 billion, but what this table is showing that basically we're losing close to $500 billion a year in losses to diseases, insects, and weeds, and pathogens alone are around over $200 billion. So this is a really important part of plant-based agriculture. So I'm going to go through a series of case studies to kind of give you some examples where plant diseases fit into sort of broader One Health. So the first one I'm going to focus on are losses due to plant pathogens. So these are pathogens that infect plants and cause reductions in yield to reduce growth of the plant, reduce fecundity, so fewer seeds, or just completely in plant death. And the impacts of these are a variety of things, from, again, the loss of a staple crop, higher crop prices, loss of incomes. And this can have disproportionate effects on low-income communities, but it fits into a much bigger picture. Probably the classic example of the impact on food security of a plant disease, at least in a modern sense, is potato lake blight caused by the fungal-like organism Phytophthora infestans. And many of you are probably aware of the Irish potato famine. So potatoes native to Mexico, South America, planted all over the world, pathogen eventually followed to Europe. In the mid-1800s, the environment was really wet. We had an explosion of this disease that pretty much devastated the Irish potato crop. Now, I think one of the things with a lot of these famines, and probably most of the audience is aware of these things, is we can't take the actual plant disease out of context of many other things with politics, colonialism. You know, there was plenty of food in Ireland at the time, so tying all this together. Same thing with a more recent one, the Bengal Famine of 1943, where several million people starved. Again, brown spot of rice initiated this, but putting this in context with war, colonialism, many other aspects that made this disease much worse. Now, we might not have had any major famines due to plant disease in recent years. However, these are still major problems around the world on smaller scales. Here's an example, cassava being a major staple crop in sub-Saharan Africa, cassava mosaic disease, this group of diseases, viral-caused diseases vectored by white flies that impact yields of cassavas. Bananas are, they didn't make my list a couple of slides ago, but they are one of the most important crops around the world, particularly in certain areas like East Africa, where they make up a significant portion of the diet for people and wildlife. And they're a big part of the lives, including for livelihoods. There are many different diseases around the world on bananas, and I could have listed a number, but these are some of the most important ones, and these have all sorts of disproportionate impacts. A disease known as Panama disease, many decades ago, pretty much changed the main commercial banana that we eat now. I like to point out to my parents that they ate a different banana when they were children than we eat now. This disease, Panama disease, has had a resurgence in recent years and is really threatening bananas across the world. getting started in Southeast Asia, but recently being found in the Americas. So this had already gone across the world. Bananas had been shifted cultivation, but now we're seeing emergence of this new disease. Another really important disease is this bacterial disease, Xanthomonas, wilt of bananas that causes fruit rotting, premature ripening, death of plants. This is a very important disease in Eastern Africa. It was first noticed in Uganda in 2001, but has spread to a number of different countries, including Rwanda, Burundi, Tanzania. And in many of these areas, bananas is a staple crop making up a significant part of the diet being consumed nearly every day. And with losses of well over 50% in some areas, this has had a devastating impact in many communities. And I like this slide because it really begins to show the necessity of a One Health approach for looking at this. Bananas become diseased by planting disease stems, but there are no antibiotics or other types of therapeutics like that for this disease. The pathogen is spread by insects, birds, bats, but it can also be through movement in tools and other types of animals. Because these are many low-income communities, some of the ideas for managing this disease often are very expensive and difficult to implement. So this is a great example of the need for a One Health approach in order to really help farmers. So through citizen science, for communication, developing cultural practices that minimize the impacts of this disease. I threw this one in since I'm giving this talk at 5 o'clock in the morning, even though coffee is not necessarily a staple crop, but for me this morning it is. This is another example of the impact on livelihoods of a disease. Coffee rust is probably the most important disease of coffee. Coffee is native to the Ethiopian highland where this pathogen is there. It doesn't really kill plants, but when you plant coffee in large plantations, it can have a devastating impact. This pathogen first emerged in the mid-1800s in what was known as Ceylon back then, spread through Southeast Asia. And this is an example of a disease that actually impacted where a crop is grown. Pretty much all cultivation was shifted in that time to South America. The pathogen finally made it to South America in the 1970s, but by this time they were fungicides, resistant plant varieties, prevent an outbreak. That has changed, and coffee rust has expanded greatly. There's probably a number of different reasons. Evolution of the pathogen. We're growing varieties now of Arabica coffee that are much more susceptible to infection. But what we're seeing is many small farmers, particularly in Central America, are being impacted by this. And, when we think of coffee, I've read many articles over the years of how it's tied into biodiversity, shade crops, linking it to the land with animals and wildlife. So this is a really important disease as it is impacting livelihoods as well. So you're seeing in many areas of Central America, millions of people have lost their jobs. This is being actually made much worse by climate change in many of these areas in Central America down into South America as well. Another aspect of microbes that are related to plants are microbial toxins. So these are primarily fungi associated with plants. Some of them are plant pathogens. Others grow on plants that primarily are impactful in storage. But they produce toxins that are directly harmful to people. So the group I just talked about were plant pathogens. These are microbes that make toxins that are impactful to people and animals. And there's a lot of these. I just kind of typed till I ran out of room here. causing all sorts of different problems on people and animals. From a historical perspective, this is probably one of the most important ones. Aflatoxin purpureae, commonly known as ergot, found in a number of different grains. It makes these little structures known as ergots. These are the structures, fungal structures, that contain all sorts of different sorts of alkaloids, primarily associated with rye, but other types of cereal grains as well. And historically, these had impacts through Europe and in North America. They're vasoconstrictors and can cause all sorts of different problems with people. There are related types of fungi that also cause problems on livestock. Many of these actually don't cause a disease. They are what are known as endophytes. They live inside of plants without causing symptoms and can actually benefit plants from herbivores. However, when consumed by livestock, cows, horses, they cause many of the same symptoms that we see that I just showed with the ergot. And particularly with some types of fescue, this can be a really important problem. Probably one of the most important mycotoxins on a worldwide basis is aflatoxins. And these are primarily produced by Aspergillus flavus, but also Aspergillus parasitica is another one. Those of you who are not familiar with the genus Aspergillus, think soy sauce. That is a very closely related species to Aspergillus flavus. Aspergillus oryzae is one of the key ingredients that goes into soy sauce, the fermentation process. Aspergillus will contaminate food, primarily in storage, but in some cases in the field. This can go directly into human consumption or into animal feed. There are a number of different forms of aflatoxins. I'm not going to get into that today, but it can impact children via milk. It can impact humans through, again, consumption of food, including things such as corn and soy. And over time, it can cause all sorts of different problems. There could be acute aflatoxicosis as well as chronic conditions. We don't see acute toxicity that often in people because we tend to eat somewhat of a varied diet. That tends to be more common in animals, but it does happen. This is an example of aflatoxin poisoning in Kenya in 2004. This was, again, associated with short-term exposure of very high levels of aflatoxin. This was also linked to drought and depressed yields of crops. So the choice between only eating moldy corn and not eating at all. And there's other examples like that. But more important is chronic toxicity, exposure to aflatoxins over a long period of time, which, along with hepatitis, are associated with liver cancer. And this is particularly a big problem in parts of sub-Saharan Africa and Southern Asia. And so this has been pointed out by many, many different people over the years. And the difficult part with this is, again, it's not just a simple thing of going in and focusing just on Aspergillus flavus. It has to be put in context of the larger food system. And again, billions of people are potentially impacted by these. And there are a number of groups that are working on this issue. That kind of leads me to another part of food safety and food security, which are pesticides. Now, when you think back to that one table I showed about losses due to pathogens and insects and weeds, on one hand, pesticides are incredibly important as a management tool to continue to raise yield and prevent crop losses. But when not used appropriately, they can have many different impacts on people, particularly children. So we see, workplace exposure, dietary exposure, residues, and this can lead to a number of different problems that have been documented around the world, particularly in low and middle income countries. So again, we have this trade-off. Pesticides are important to maintain yields, but we must consider the other impacts of pesticides. Again, particularly in low and middle income countries, where often there are not regulations to mitigate these downstream issues of pesticides. I don't really want to just completely point the finger at low and middle income countries. High income countries also have issues. I live in California, one of the biggest agricultural states in the country. There's still, I read all the time about the various issues around worker safety. Again, there's a lot of regulations, but things sometimes fall between the cracks. Another issue is overuse of pesticides, particularly where similar pesticides are used in plants and with animals as well. And, we hear a lot about AMR, and we see the same thing happening with fungicides as well, particularly triazole. In parts of Europe, use of some of these triazole fungicides on plants is leading to resistance in fungi that will infect people and animals, especially Aspergillus fumigatus. So I've focused on these first couple examples of pathogens of plants, although some of them make toxins that directly impact people and animals. But this last example I want to look at are human pathogens associated with plants. So food safety from sort of the classic example here. And when we look at common sources of food poisoning, plants are an ultimate source, probably of about 50% of all outbreaks of food poisoning. And you see some of the common ones here: Salmonella, E. coli, Campylobacter, Listeria. This is what I downloaded from the CDC, their investigations of foodborne outbreaks this year. You can see pretty much all of them are associated with plants. We consider mushrooms as a plant in this case. And this is from 2019, that again, about half of the outbreaks were associated with plants. And it's the same thing in 2018, 2017 as well. So when we think of food safety, we think of many areas where plants can be contaminated with human pathogens. And I guess as the panel that's coming right after, we'll talk about some of this as well. I'm going to focus here in the field. And again, this is a great example of the importance for One Health. I think the other point is nowadays we see that plant-based agriculture in general, is a worldwide commodity. It's traded all over the world. Crops are moving in many different areas. And I like this one from the Institute of Medicine showing often where many of our plant-based commodities are grown all over the world. These outbreaks happen all the time, and oftentimes it's a similar sort of issue. Plants grown in proximity to animal agriculture. This is a slide from 2006, again looking at dairy being adjacent to lettuce fields. This is an example with spinach, and we see cattle, but also feral pigs and other wildlife that are right in proximity to areas where they're growing leafy greens. So these slides are from 2006, but just over the last couple of years here in California, we've had a number of different outbreaks. This one's from headlines from 2018. And just when thought it was over, another outbreak. There was a series of outbreaks in 2018, 19, and into early 2020 with lettuce associated with E. coli. And the most recent one, this is a report from the U.S. Food and Drug Administration looking at where the E. coli came from. And again, this issue of cattle grazing near where leafy green fields. So I think, again, this is a great example of something that requires a One Health solution with looking at animal agriculture, looking at plant agriculture, and the specialists and farmers of both of those. And my last example, again, goes back to other locations where we have this idea of mixed agriculture. Nipah virus being a very important disease in parts of Malaysia, Bangladesh, that we associate with humans and pigs. But a lot of this is tied to sort of a mixed agriculture. In parts of Malaysia, we have sort of this mixed agriculture, again, where bat to pig transmission via bats feeding on fruit, that again with mixed agriculture, or on date palms. So understanding transmission of Nipah also requires understanding how people are utilizing plants for nutrition as well. So tying all these things together, I showed those slides at the very beginning, looking at how One Health is embedded in all these transdisciplinary approaches. And plant health approaches to plant health have gone that way many times. There's something that we often hear about in plant health known as integrated pest management. So this was started to link plant pathologists with entomologists, with lead scientists, as we begin to look on how to maintain yield and plant health by really bringing different specialists and farmers together. And here's a figure that I got from our University of California Extension folks. In many respects, this looks like that figure I showed of One Health way back in the beginning of my talk. Again, a transdisciplinary approach. So when we think of One Health, a lot of times in my view, and I've been going to a lot of these One Health type meetings, is plant specialists and One Health specialists are often doing similar things, but often just not talking to each other and having the same thoughts. And finally, I just wanted to throw out one other thing is, I've mostly been talking from the standpoint of disease control, disease management, but I think having plant scientists, human, animal disease specialists all talking at the basic research as well is also important. This is a paper I was a co-author on it a number of years ago, trying to bring that together. And so there's a number of different things that there are similarities between plant diseases, human diseases, animal diseases, and how we can learn from each other in certain ways of studying these. In some respects, as plant pathologists, we have it a little bit easier. There's certain experiments that we can do that ethically people who work with animals and people cannot do. And I think those sorts of things are very helpful as we expand out and really try to bring things together in One Health. So that was a whirlwind tour of plant health. I just skimmed over many different areas, but I hope I've convinced at least some of you that plant health is an important part of One Health. now and certainly moving forward. And I really would love to see a dialogue between One Health practitioners and certainly my field in plant pathology. So I hope I have left some good time for discussion and questions. I would like to acknowledge the number of different groups that I've worked with on One Health, including the One Health Action Collaborative, the National Academy of Medicine. Sally Miller, who just introduced me, is also part of this, and we are continuing various dialogues there. So thank you very much, and I am happy to answer questions or start some sort of dialogue.
Well, thank you, Dave, for an excellent presentation. And there is one question in the Q&A. Can you see it?
Let me see if I can pull that up here.
From Eric.
Monoculture and industrial agriculture is very important because such crops are more vulnerable to plant pathogens. To what extent are crops grown for household food, monocultures, if known? So, certainly, I'm not sure I quite get the last sentence a little bit, but certainly we see diseases in household food as well. And some of the groups that we've worked with, particularly I had experience working with groups in the Philippines, for example, where you have small plots, but we also see a lot of mixed agriculture in these areas. So we have different types of diseases. So some of the diseases of large agriculture, maybe less, but we have other diseases in small family plots. Does that answer your question, Eric? I'm not quite sure if Sally probably has some really good examples on some of those on that particular one. I know she works with a lot of these different things.
I'm sorry to interrupt. I would like to remind our participants you can raise your hand and we can unmute you so you can ask your question out loud. Please go ahead.
Yeah, so there's another question about antibiotics in plants. Typically, antibiotics have not been used as much on bacterial diseases in plants, although there has been a thing with a citrus disease, citrus greening in Florida, where there has been some use of, and Sally can correct me if I'm wrong, tetracycline being sprayed over large areas there. So the vast majority of plant disease are caused by fungi. So it's fungicides that are most important ones. So antibiotics that go between animals and people and plants are not as big of an issue. That's why I gave the example of the fungicides. But there are some examples in there.
I have a question,
Yes.
David. This is Melanie Ivy. I just wonder, well, two things. I'll add fire blight and Erwinia amblyovora as an example. And we have detected streptomycin-resistant Erwinia in our fields in Ohio, and I know that it's present in other states as well. My question is if you could maybe just address a little bit post-harvest diseases and the role that they might play in One Health.
Yeah, and the post-harvest diseases are real important. I mean, a classic example of that are some of the mycotoxins that I talked about, but they can also lead to very large loss of crops, particularly in places that don't have, ways of storing crops for long periods of time, where we have to store grains and other things. So I think, we often think of the fields, but that storing plants afterwards can be really, really important from a plant disease perspective and for livelihoods and many different other ways.
Thank you.
You mentioned, Dave, the azole resistance issue, which really is started awareness in Europe. I find very little awareness of this in the U.S. But on the other hand, those azoles are very widely used. Do you see this coming to a head?
It's probably going to come to a head in the United States as well. I mean, obviously in Europe, I mean, the countries, I think the Netherlands was where some of this first popped out, much more densely populated. They're in areas where the fungicides are being used, but certainly in a place like California with a very large population, I think we're going to probably start seeing something this as well. I think that was a real wake-up call for the U.S. as well.
Are there other questions? I will follow up on Ram's question about antibiotic use. He was talking about off-label use.
Okay.
I have heard, anecdotally of use of streptomycin in the tomato fields in Mexico. Do you think that is significant, or is just an off-label use here and there?
Is that for me?
Yeah.
Yeah. I have to admit, I'm not an expert on the antibiotic use. I don't work on bacterial diseases. I've certainly seen, I remember there was an article in Science or Nature a couple of years ago about antibiotic use in plant pathogen, and they interviewed plant pathologists that had both perspectives, that this is something that potentially could be really important, whereas others said, well, it's not used enough, really. And so I don't really have a good perspective on that, and some of the plant pathologists who are watching Sally and others might have a better perspective on that. I know streptomycin is not used all that much out here in California, but in much wetter areas like in Ohio and eastern United States, for fire blade, it can be used more. And I know there was definitely some thoughts of using it for citrus screening in Florida, but I don't know the longer term implications of that. I think others would be better to answer that question.
Well, our time is up now, and I'd like to thank you, Dave, for a really enlightening presentation.
Well, thank you for the invitation. I'm going to enjoy the next panel as well.
Thank you so much to both of you for the presentation and those questions. I will turn it over to our panel discussion led by Dr. Barbara Kowalczyk.
Good morning and good afternoon. My name is Barbara Kowalczyk, and I'm faculty here at The Ohio State University, and my background is in epidemiology and biostatistics, and I focus on food safety. So our panel this morning is going to focus on food safety and really fits in well with the previous speakers' comments and presentation on One Health. I think, as we all know, foodborne disease is an important global health issue that sickens millions of people each year, and the complexity of our food system makes it really difficult to manage food safety risks across the world. Risk-based approaches are internationally accepted as the best way to effectively reduce foodborne disease or risk of foodborne disease, and today we have three excellent speakers who are going to talk about these issues. Our first speaker, Dr. Ari Havilar, will be presenting on the burden of foodborne disease. Dr. Havilar is a preeminent professor of global food safety and zoonoses in the Animal Science Department, the Emerging Pathogens Institute, and the Food Systems Institute of the University of Florida in Gainesville, Florida. His research focuses on epidemiology and risk assessment of foodborne and zoonotic diseases and their prevention in the United States and globally. Dr. Havilar has published extensively on the global of foodborne disease, including his role as chair of the World Health Organization's Foodborne Disease Burden Epidemiology Reference Group. His current research is funded by the Bill and Melinda Gates Foundation, the United States Department for International Development, and the UK's Department for International Development and the Florida Department of Health. Our second speaker is Dr. Kang Zhao. He is a food safety and quality officer at the Food and Agricultural Organization of the United Nations and will be presenting on FAO's recently published guide to ranking food safety risks at the national level. Dr. Zhao is one of the secretariats of the joint FAO World Health Organization expert meeting on microbiological risk assessment, which provides microbiological risk assessment and scientific advice to Codex Alimentarius to support the development of international guidelines and standards, and also transfer technology to member countries for capacity development. Our third speaker, Dr. Robert Ansari, will be presenting on the application of risk-based approaches to food safety in Kenya. Dr. Ansari is a senior research scientist at the Kenya Medical Research Institute and GOHI's Kenya Liaison Officer. He has expertise in molecular epidemiology, genomics, and bioinformatics of infectious diseases. The overarching goal of his research is to develop preventive strategies, control measures of antimicrobial resistance in enteric infectious diseases, including discovery of new vaccine targets. He has worked on antimicrobial resistance surveillance and monitoring, molecular and epidemiologic characterization of enteric pathogens obtained from hospitals, communities, and food animals in both outbreak and non-outbreak settings. We will be taking questions after all three presentations have been given. If you have a question, please enter it in the Q&A chat box, and you will be unmuted when it is your turn in the queue. With that, I invite Dr. Havilar to kick off our discussion.
Dr. Havilar, you're still muted.
Can you hear me now?
Yes, sir.
Okay, then do you see my slides?
Yes, we can see them.
Okay, great. Okay, so thank you, Barb, for organizing this session and inviting me to participate. I look forward to our discussions and will be happy to present some of the work that has been generated by the World Health Organization, the Foodborne Disease Burden Epidemiology Reference Group on the burden of foodborne disease and focusing specifically on the burden in low and middle income countries. First of all, what I would like everyone to be aware of is that it's really difficult to quantify the societal impact of foodborne diseases, whether it's the burden, whether it's the economic cost, whether it's any aspect of foodborne disease that affects society. And there are many different reasons for that. One of them is that there are many hazards. Textbooks on food safety mention some 250 plus potentially foodborne hazards that can affect human health. And they're in very different domains: viruses, bacteria, parasites, chemicals, toxins, prions. And they cause very different health outcomes, ranging from acute intoxication 2 hours after you've eaten a meal that was contaminated with Staph aureus toxins, you already start vomiting, up until examples that were mentioned in the previous talk, Aflatoxin, that only exerts its effects typically after decades of exposure. Health outcomes, diarrhea, but also birth effects, epilepsy, cancer. So there's not one medical registration system that will capture all the impacts of foodborne disease. Even more important, many cases go unrecognized because patients may not even have medical contact, or the surveillance systems are very weak, or because of all the problems above, it's very difficult to attribute the disease to the foodborne exposure. And adding to that is that when we look at many foodborne hazards, be they bacterial, viral, chemical, they don't only have food as their transmission pathway. They can typically also be transmitted by water, or by human-to-human spread, by animal-to-human spread, or from contact with the contaminated environment. And these proportions will vary largely across populations, across hazards. So even if we have the burden of a specific health outcome that can also be caused by food, we still don't know what the foodborne disease burden is, because we have to partition that burden into the different transmission pathways. So in my opinion, fully quantifying the burden of foodborne disease is virtually impossible, but still we can make meaningful choices. We can focus on things that we know, we can focus on things that we consider to contribute most to the human disease burden, and work from there and gradually strengthen our ability to estimate that burden. So where can we look when we look at indicators of foodborne disease? Of course, health indicators are one of the major indicators that are being used. Incidence, mortality, summary measures of public health. I'll talk a lot about that in the next slides. We can also look at economic impacts, cost of illness, but also regulatory costs, compliance costs, costs of outbreaks, costs of recalls. We can look at hazard occurrence in food chains. Where do the hazards occur and can we act on them? We can look at how food system inspections function, and we can look at value chain actor behavior. So there's different ways that we can try to probe, is the food safe? Some of them require a lot of integrated work. Some of them are maybe even observable by an individual consumer. And of course, one real question that we're still struggling with, how can we convey information about the safety of the food that people eat to the consumers themselves? Because a lot of this requires a lot of very specialized scientific work. Countries that are embarking and have embarked on these studies, like the United States, but also countries in Europe, like the United Kingdom, my home country, the Netherlands, are now routinely publishing studies on the burden of foodborne disease in their country. One thing that has been hotly debated in the last year or so in the relationship, for example, to Brexit, is how comparable are these numbers? Can we compare US and UK estimates of the burden of foodborne disease? And the simple answer is no. Every country works with the data they have, with the traditions that they have, makes different choices along this way, and it makes it very difficult to compare those numbers at face value. So some kind of international effort is needed to coordinate these estimations and to make comparisons also between countries meaningful and possible. Where do we get data from? This is what is called the surveillance pyramid in infectious diseases epidemiology, where we start with all infections, symptomatic or asymptomatic, and often we'd like to know about also asymptomatic infection. For example, the current coronavirus epidemic is a good example, where we don't only want to know if a person is symptomatically infected, but also asymptomatically infected, to have a good view on what's happening in the population. A proportion of all infected persons will go on to be symptomatic. I already told you that these symptoms can be very different. And a proportion of them will choose to go to their doctor. But a proportion never is seen by the medical system. If they go to the doctor, then of course the next step is, will the diagnosis be made correctly and will it be made specifically? For example, if you go to the doctor with a case of diarrhea, the advice may be just to sit it out, to wait a couple of weeks and see if it's over. Only in a small fraction of the cases will the doctor ask you to submit a stool sample that can be analyzed by a diagnostic lab, and then come to the conclusion that you have been suffering from campylobacteriosis, salmonellosis, ETEC, STEC infections, whatever. And then the final step those cases that have been diagnosed by a medical lab, by a doctor, need to be reported to the public health surveillance authorities at the regional or the national level, and only then will they appear in those statistics that we routinely see. So we call this the tip of the iceberg. For example, here in the United States, for every case of salmonellosis that is reported, there are about 39 cases that are not reported. So why is this also difficult? The decisions that are made that inform this surveillance system are made in the healthcare system for the purpose of treating patients, not for the purpose of public health surveillance. And these decisions, they are not consistent between countries because maybe of different insurance systems, different practices in medicine. They can even be different between regions or smaller geographical systems. They change over time. A current challenge is the increase of non-culture dependent diagnostics that reduces the ability of public health authorities to type strains in help of searching for outbreaks, for example. There can be budget limitations that restrict testing of samples, and the testing can be incomplete. No laboratory tests diarrheal samples for all potential diarrheal pathogens. So if you don't test for a particular pathogen, you're not going to report it. Then there's the timeliness. When you think about outbreak studies, it often takes weeks before the outbreak is recognized, and when public health authorities then go back to the patient may not really recall what they've eaten and when exactly they have eaten it. Food samples that you would like to test may no longer be available. And the overarching conclusion of this is that if you want to estimate the burden of foodborne disease, you need to synthesize many different data sources, and you need to impute a lot of missing data by some kind of statistical method or expert judgment. The public health indicators for the burden of foodborne disease, the common indicators are the number of illnesses and death. Increasingly, we're using a concept called disability-adjusted life years, and you can consider a disability-adjusted life year as one healthy life year lost. It's one of the examples of the summary measures of public health that try to integrate morbidity and mortality, looking both at disease occurrence and disease severity. There are two components to the DALI metric, the years lived with disability and the years of life lost. The years lived with disability focus on morbidity, and we calculate them by estimating the number of incident cases, estimating the duration, and some disability weight between 0 and 1 to reflect the severity of the disease. And if you multiply those three components together, you have the YLD. The years of life lost are calculated by counting the number of deaths, premature death, and the residual life expectancy of an individual at the age of death, typically looked up in a statistical life table. And it's important to note that these studies do not only document the current disease burden, the burden in this year, but also look ahead, the future burden, the sequelae, the impacts of chronic exposures. If you're exposed to a chemical today, you may only suffer from that disease a few decades later. But if we would be able to prevent that exposure, we would also prevent that disease that comes much later. So in terms of trying to estimate the effects of interventions, it's important to document both the current and the future burden of foodborne disease. So the World Health Organization has published a major report in 2015, quantifying the burden of 31 hazards, viruses, bacteria, protozoa, helminth, and chemicals, documenting 600 million illnesses. In other words, every year, 1 out of 10 global citizens gets affected by foodborne disease. And of these, there are 420,000 deaths and 33 million healthy life years get lost. A group of scientists within the FERC has published additional studies on 4 metals in 2019, documenting another 1.1 million cases, 56,000 deaths, and 9 million DALIs. I must note that these are not WHO estimates because not all the methods do concur with the requirements of WHO, but they are probably still very realistic estimates of the true burden. So we're currently looking at a huge burden of foodborne diseases across the globe. There are many more hazards. Dr. Ritzel mentioned pesticides, for example, that we would like to document, but they are currently not quantifiable because just the data lack is too large to make any estimates realistic. At least that was the judgment when the FOOD committee was working on these estimates before 2015. WHO is now developing a strategy to update estimates by 2025 and also develop a food safety indicator. A resolution to support that was adopted this year at the World Health Assembly, and WHO is now in the process of setting up a second FOOD committee to start working with them on these new estimates. The 2015 estimates, if we break them down a little bit more, you can see that the vast majority of foodborne illnesses is caused by diarrheal pathogens, and also about half of the foodborne death is caused by these pathogens, and just over half of the foodborne DALIs. So these are definitely a major focus of foodborne disease prevention. Looking at the invasive infections, the helminth and the chemicals, you see that the incidence of these diseases is much lower, but they still contribute significantly to the number of deaths and the number of DALIs, reflecting the fact that infections or diseases associated with these hazards are often more severe than those associated with diarrheal pathogens. And you can also see that in the 2019 estimates, where 1.1 million cases of cancer, mostly by foreign metals, still cause a foodborne disease burden of 9 million DALIs. So that's why it's important not only to count the number of cases, but also look at the impact in terms of morbidity and mortality. This is an important diagram when we start thinking about preventing these foodborne diseases, because they are very unequally distributed, particularly children under 5 years of age. They only make up 9% of the world population, but they suffer from a large proportion of foodborne illnesses, death, and DALIs. There is a very unequal distribution also in the world. The poorest areas of the world, 41% of the world population succumbs to 75% of the foodborne death. And it's particularly the children in lower middle income countries that suffer from foodborne diseases disproportionately. The data also allow us to zoom in on the burden of specific foods. These are two examples of studies that we have been doing in my lab as follow-up to zoom in on the burden of animal source foods that contribute about 35% of the burden of foodborne disease. And then within the animal source food, zoom in on dairy products contributing 12% of the total burden. Again, you see a very unequal distribution with a high burden in Africa, also a relatively high burden in the Eastern Mediterranean. But when you look at the color codes in those two regions, they're very different, meaning that in Africa, different pathogens are important in causing foodborne disease, particularly Mycobacterium bovis and Campylobacter, Salmonella, whereas in the Eastern Mediterranean region, for example, Campylobacter is a much more important pathogen. And Brucella, you see Brucella here in the dark, a very important pathogen in one of the Eastern Mediterranean regions. So this kind of information, actually even better at country level, is needed to help to inform food safety decision makers on what are the priorities in their particular country. Since the publication of these estimates, they have had a major impact on the global thinking about food safety. There is now a Food Safety Day, 7th of June every year is Food Safety Day. It's also becoming increasingly recognized that food safety is an integral component of food security. A statement like, if it isn't safe, it isn't food, has now become very common speak also in the nutritionists community. Food safety decision making is often, if not always, the responsibility of national governments. The FOOD estimates were published for governance reasons at sub-regional level. We need, as I said, country level estimates. They are available. All the calculations of FOOD were done at the country level, but they need to be cleared by the national authorities. And their interest would be that the national priorities may not be fully represented in the global estimates. And we also, Barb and I and her co-workers are working particularly in Ethiopia at the moment to use the FOOD data to support local decision making. What we're also very keenly aware of is that national decision makers need training in risk-based decision making. I look forward to Dr. Osara's presentation on that. One thing that we are currently developing to support the national food safety decision makers is a dashboard where the Ethiopian authorities can consult the FOOD data in an interactive web-based tool. This is just a screenshot that's populated with hypothetical data because we're still in the process of releasing the national data together with the Ethiopian authorities, but somewhere next year this dashboard should become publicly available. Now I want to talk a little bit about the limitations of the FOOD estimates. There are many. Data availability and quality is an important problem, particularly in low and middle income countries. As I mentioned, we have a limited number of hazards, and very importantly, given the available data at the time, very important endpoints were not considered. And I'm going to spend the last part of my talk on the evolving insights in the links between malnutrition, stunting, and foodborne pathogens. Stunting, as you may know, still a major problem in the world, affecting 25% of children globally, and even 35 to 40% in Africa and African countries. It's associated with increased mortality, impaired cognitive development, reduced income, reduced life expectancy, and increased risk of chronic diseases later in life. For example, India now sees an epidemic of obesity that is partly caused by the fact that a lot of children, people that are now suffering from obesity, were stunted early in life. We need interventions to reduce this cause of morbidity and mortality. We need more interventions because we're not on track in reaching the Sustainable Development Goals for the prevalence of stunting. The UNICEF has published a framework in the 1990s already that addressed two important underlying causes of stunting: poor diets and occurrence of common infections such as malaria, diarrhea, and lower respiratory gut infections. What has become clear in recent years is that there's actually a third pillar that is necessary for normal growth and development, and that's good gut health, a well-functioning intestinal system that's able to absorb nutrients in an efficient way. And this is where the link with foodborne pathogens comes. This is two maps that I found. One is from GAIN, looking at the global distribution of stunting. One is based on the WHO data by a YouTube blogger that recently spent some attention on foodborne diseases. And you can see that there is a global juxtaposition of nutritional and food safety impacts. That doesn't mean there's a cause and effect relationship. At least there is a double burden in these countries. But I think more and more we understand that there are cause and effect relationships also underlying this juxtaposition. And a lot of that information comes from a multi-country project called MELI-D, where they are documenting that enteric bacterial infections and also mycotoxins are increasingly associated with stunting through a common underlying condition that's called environmental enteric dysfunction, where the normal lining of the gut gets degraded by chronic infections. The villi are blunted, cannot absorb the nutrients. We get leaky tight junctions, we get local and systemic inflammation, and children spend their energy on fighting the infections rather than on growing well. There's a lot of mechanistic insights that support these observational studies. One of the main pathogens that has been recognized as contributing to these chronic infections is Campylobacter. Again, the MELI-D study has documented that they are associated with linear growth faltering and inflammation in the gut in low and middle income countries. And you can see here that there is a significant relationship both on the height for age z-score, an indicator for linear growth, and fecal myeloperoxidase, an indicator for gut inflammation. Well-known species, Campylobacter jejuni and coli, do have significant associations. But look here, there's a lot more. There are currently 40 named species of Campylobacter. 2 are the ones that are most studied. There are 38 that are much less studied, but they appear to have a much bigger impact on stunting than the well-known thermophilic Campylobacters. We know a little about the reservoirs of all these Campylobacters, certainly in low and middle income countries. The non-thermophilic Campylobacters typically are reported from mammals. These are also strongly associated with chickens. So livestock in general is an important way, and we know that there's a lot of cohabitation of humans and animals in many areas of the world. So I think this is the real One Health challenge here. How can we understand these transmission cycles and break these transmission cycles? And this is where 2 projects where the University of Florida and Ohio State University are collaborating in a very intense way. Also with the GoHi office in Ethiopia, we also have as Haramaya University in Ethiopia as our partner, Washington University, Massey University, but the OSU axis is really key in these projects. The CAGE project looking at the reservoirs of Campylobacter species in young children, in adults, in livestock, other reservoirs in the Haramaya Woreda in Ethiopia, try to attribute that and link that to gut health and health status overall in children. And the XCAM study, where we try to ask the question, when we know the reservoirs, how do the bacteria move from the reservoirs, from the cattle, from the chickens, from the goats, from whatever the reservoirs are, to the children? What are the exposure vehicles and which of those are most important, so that we know where to focus when we want to intervene in these transmission pathways. So my conclusions. The global burden of unsafe foods is substantial, and a large share of that burden is borne by children under 5 years of age and those living in low-income countries. The priority hazards differ between regions, and nutrient-dense foods, be they animal proteins, be they plant foods, are more likely to cause foodborne disease than staple foods. Emerging evidence links foodborne enteric pathogens, specifically Campylobacter, to poor gut health and stunting. And looking across the board, control methods do exist for many hazards. Many countries are implementing them successfully, or at least more successfully than many other countries, but they are linked to economic development and effective food safety systems. Developing a consistent set of food safety indicators that is comparable between countries requires international collaboration. So thanks for your attention. Barb, back to you.
Thank you very much, Ari. Now I'd like to invite our next speaker, Dr. Kang Zhao, to present. And Dr. Zhao, if you could unmute your microphone, and Ari, if you could mute, that would be great. Thank you.
So can you see me now and hear me? Yeah, okay. So good morning, good afternoon, and even good evening to everyone. I'm Kang from the FAO, and it is a pleasure to give this presentation on FAO Food Safety Risk Ranking Framework today. Food safety has always been an important issue, and currently it is high political agenda of many countries. So it is highly related to the UN's SDGs to eliminate the poverty, zero hunger, keep good health, and support economic growth. New risks and challenges are emerging as a result of changes in the methods of food production. The expansion of international trade in food has increased the risk of microbiological and chemical hazards being transferred from the original points of production to locations that might be thousands of kilometers away. The most efficient way to deal with food safety issues is not to address them after they happened, but to prevent. So preventive measures and an integrated approach is the key, and the food safety management makes food safety a shared responsibility. To tackle the food safety issues, the consensus is to use the risk analysis tools. Risk analysis is internationally accepted as a key component to support decision-making around food safety. Risk analysis is defined by Codex as a process consisting of three components: risk assessment, risk management, and risk communication. From the international level, Codex is in the risk management position to develop the international standards and guidance with its members. The FAO and WHO provide scientific-based evidence to support Codex work, and we all communicate in the international platform. As I just mentioned, the risk assessment work is supported by FAO and WHO Scientific Advice Program, which includes the joint FAO and WHO meeting on microbiological risk assessment, which I'm currently working with. The expert committee on food additives, which is the JECFA, and also JMPR on the pesticides, and also JMNU on nutrition. So for risk management, the first step consists of preliminary risk management activities. The food safety issue has been identified. Available scientific information is aggregated into a risk profile that will guide further action. The goal of the risk management will be established, and also be conduct a risk ranking on food safety. The steps afterwards, including identification and selection of risk management options, implementation of risk management decisions, and also monitoring and reviewing. But we will focus with the risk ranking. So why we need risk ranking? With the limited human and financial resources, it is impossible for national authorities to efficiently address all food safety threats. Therefore, it is important to rank food safety concerns and prioritize efforts so that resources can be allocated to most efficiently and minimize the foodborne illness risks. Food safety risk ranking is the systematic analysis and ordering of foodborne hazards and of foods in terms of public health risks based on the likelihood and the severity of adverse impacts on human health in target population. However, the multitude of hazards and foods, complexity of methods, data need, and the resource-intensive nature of risk ranking efforts often pose barriers to wide adoption. Therefore, the FAO worked to provide scientific recommendation and facilitate the use of risk ranking in national food safety programs, which include making informed regulatory decisions, enhance disease surveillance, determining how food inspections are allocated, overseeing inspection and enforcement food safety efforts, inform the public of food safety threats, and also continue to improve the safety of the foods. It is also need to clear that the term that risk ranking and prioritization are often used interchangeably, but they have different meanings. Risk ranking is only based on public health, but prioritization also includes, for example, social, economic, and also political considerations. However, when the risk ranking has been conducted, the prioritization is the next logical step and the critical part of the decision-making process. When there is an emergency of food safety issues, a need to prioritize legislative activities, ranking of food business operation based on their levels of clients or informed national sampling program, we still need the risk ranking. So here we proposed approach was developed with input from FAO and also the expert panel. It focused on microbiological and chemical hazards, but it could be also adapted for other hazards like allergens. There are 3 steps, which begin with define the scope, including define the purpose, select what will be ranked, and screen foods and or hazards for overall relevance and risk potential. The second step is to develop the approach by selecting the risk ranking methods, selecting the matrix for risk ranking, and collecting and evaluation the appropriate data. The first and most fundamental step in risk ranking is define the scope, which will guide all activities. Simply, why are we doing it? We suggest draft a state of concern and a state of purpose objectives that describe in simple terms that the motivation for conducting a risk ranking exercise and the management goals that need to be addressed. The foods and hazards to be evaluated in the risk ranking process should be based on the goals of the risk ranking and defined by the risk manager and policy makers. The selection of the food and hazards to include in the ranking process is based on a variety of concerns or factors described previously, including the outcome of the interest. The risk manager will need to determine which food are relevant. All foods, a subset of foods or specific foods. The risk manager will also need to determine which hazards are relevant. All known microbiological and chemical hazards, a specific type of hazards, for example, just chemical hazards, a subgroup of hazards, or specific hazards. So risk manager will likely need to rely on the expertise or their technical experts to identify and initiate a list of potential foods and hazards. So here we are proposing some examples of the microbiological and chemical hazards in the table. And also, we propose this, we recommend this kind of food categories from FAO and also some other organizations. It may be tempting to include all the foods and hazards for a government that appear to match the goals and objectives for the risk ranking, but it is not practical and frequently not appropriate. Therefore, it is important to screen the food and hazards to be included in the model based on the stated scope to reduce to a manageable list. Developing a decision flowchart like in the right of this slide with yes or no outcomes and well-defined cutoffs could be helpful for screening potential food or hazards for inclusion in the risk ranking. With scope finalized, the approach for ranking the risks according to their public health impact needs to be developed. The process for developing the approach is not linear and is often iterative. For example, the development of the risk ranking approach may be driven by data available in one situation while being driven by a preferable method in another. There are many methods and tools that can be used to conduct food safety risk rankings. Briefly, risk ranking methods are generally categorized as qualitative, semi-quantitative, or quantitative. But it is important to aware that this is different than the qualitative or quantitative risk assessment, as the risk assessment assess the risks, and as I mentioned before, the risk ranking mainly assess the hazards. So it is only qualitative and quantitative methods here we used. It is also need to be aware that the preferable way, given limited resource and time, is to do risk ranking in a most efficient and appropriate way. So the qualitative methods were more employed as the merit of it. We had a lot of capacity development training course in the low and middle income countries, which showed that the qualitative methods like the decision tree is more efficient. But the disadvantage is clear, that there is uncertainty and it needs clear definition. So if we have moderate resource and data, we could have scores allowed to rank items but do not provide a direct measure of the risk. This is also qualitative, so it can be implemented rather quickly. There are several developed tools like risk metrics, multi-criteria decision analysis, and also risk ranking. For the quantitative methods, which requires the development of mathematical methods, it is obviously robust and able to provide estimates of risk and magnitude of difference between items being ranked. However, it is more complex, require good technique expertise and resources. Sometimes the expert's opinion can be incorporated to fill the data gap. And we have an example like the WHO burden of the disease methods. So risk is calculated as a function of the likelihood of illness, which is the probability that the illness occur, and also severity of the illness. The item listed here shows the potential matrix could be used for risk ranking of microbiological and chemical hazards. The goal of the risk ranking exercise should be to obtain results that are reliable, scientifically valid, repeatable, and transparent. Achieving this goal requires timely and also representative data. Data requirements for risk ranking vary according to the approach, the method, the hazards being considered, and the matrix selected. But the data need to be accurate and precise. Ideally, hazard-specific epi and also source data would be obtained through country activities, for example, the surveillance system. However, few countries have such systems and must rely on data from reported cases, surveillance sites, cohorts, and case control studies, and the published literatures. Source attribution study can be also used to estimate the proportion of illness that are associated with specific foods. After collecting and evaluating the available data gap must certainly identified. How these gaps are addressed will largely be driven by the needs of the risk manager and also the available financial resource decision with great uncertainty. Two options are suggested here. One is to use regional or international data as a surrogate in these situations. For example, when the focus in microbiological hazards, the WHO FERG estimates might be a good place to start. And also the experts' elicitation can also be used to fill the data gap by quantifying strict methodology in structured matters. The next step is to estimate and rank the risk based on the matrix for severity and likelihood using the selected models. Results from a risk ranking exercise must be interpreted with caution, taking into consideration the bias, the uncertainty, and variability inherent in the matrix and the data and methods used in the analysis. Relative risk ranking charts are a good appealing way to present the results of the risk ranking and can be easily understood. Like the plot at the upper right, and also the example of microbial hazards at the bottom right. Plotting the two dimensions of risk on scatter plots provides a high-level information of the relative risk ranking for each of the hazards and might be enough to inform risk management decision. So this is the proposed approach from FAO which we hope can be considered as a starting point, since risk ranking is complex and must involve as new data and information. So we like to welcome all the data and suggestions. And we also like to thank Julian and Barbara who led this work, and also all the experts involved, as well as all the colleagues from the FAO who supported this work. And thank you.
Thank you very much, Dr. Zhao. And I'd like to now present our third and final speaker of the panel, Dr. Robert Ansari. Dr. Ansari, can you share your screen? Oh, thank you. Dr. Ansari, you're still on mute.
Hello, can you hear me now?
Yes, thank you.
Thank you very much. And can you see my slides?
Yes.
So thank you very much. Thank you, Barbara. Thank you very much for organizing this session, and thank you for inviting me to speak at this session. And thank you very much for introducing me. So what I would like to do this evening in Kenya, it's now evening in Kenya, is to share with you some perspective from Kenya, which is an example of a low middle income country. So the title of my talk is Applying Risk-Based Approaches in Kenya. So the outline of my talk, I will talk about, I will give you a context of my talk by going through first risk analysis paradigm, trying to understand what we understand by risk analysis. I will then talk about why is food safety important. Then I will talk also about why food animals are most important source of foodborne diseases, which gives us a one health, which makes it a one health issue. I will also talk about microbiological risk assessment. Then I will share with you a perspective from Kenya on risk-based approaches. I will also talk about the risk assessment in Africa, informal sector, why informal sector matter. Then I will also talk about why participatory risk assessment is important. Then just to give an example of the risk analysis paradigm, I'll share with you a project that we are about to start implementing in Kenya, Chakula Salama, project that we are doing collaboratively with other institutions. Then I'll give a few conclusions and finally acknowledgement. So I'm glad Dr. Zhou talked about, introduced the risk analysis paradigm. So the risk analysis contains three key elements. That's risk assessment. And here, it's very important to talk about the scientific advice as well as information analysis, talk about studies to try and understand the risk assessment. The other important aspect on the risk analysis is risk management. Here, we're talking about regulation and control, rules on food safety and so on. The third important component of risk analysis is communication. Communication is very important. It's very important to talk with, have a conversation with all the stakeholders that are involved. But why is food safety important? So earlier on, Dr. Havela really gave a very excellent talk on the burden of foodborne pathogens. But I just want to add on to his remarks about the burden of foodborne pathogens. Globally, annually, there are about over 3 billion cases of diarrhea, and 0.5 million deaths of children below 5 years die of diarrhea. So Africa is disproportionately affected because 8% of young children die due to diarrhea. It's also important to note that food animals are actually the most important source of foodborne diseases because they're considered vehicles of most of the foodborne diseases. Just to explain this a little bit, why we consider why food animals are the most important source of foodborne diseases, by answering this question really brings out the truly One Health nature of this problem. This is because of the interlinkages, interrelatedness of the various aspects to do with food animals. There are zoonotic diseases that are associated with food animals. Here we are talking about, and I remember Dr. Havila touched this. We're talking about bacterial, viral, parasitic disease, and so on. Again, we also have food. We harness food from these food animals. Products such as milk, meat, eggs, and so on are produced by these animals. There's also interaction with the environment. Chemicals, pathogens, allergens, and so on interact very closely with animals. Again, the human side, we have close interaction with the food animals. We have social talk about pastures, traffic accidents, and so on. And again, when you look at the animal-human interface, again, the examples such as manure, aesthetic reasons. So what these examples tells you is that food animals are truly vehicles for foodborne diseases. And so it's very critical that we consider it as a very important vehicle for foodborne pathogens, foodborne diseases. Talking about a little bit about microbiological risk assessment. The microbiological risk assessment is carried out for pathogens or food combinations that are associated with foodborne illness. For example, you're talking about your ice cream. Here, then you have in mind isolation of bodies such as salmonella. Sandwiches, here what comes into mind are pathogens such as E. coli and so on. Really, so microbiological risk assessment is a key element of risk analysis. Now, in Africa, the informal sector is an important component that must be one must bear in mind when you are talking about the risk assessment. Why are we saying that? So, looking at a few publications from Sub-Saharan Africa, a few countries from Sub-Saharan Africa, a large population from these countries actually belong to the informal sector. They either have informal engagement or live in informal settlements, slums, and so on. So another important factor to consider as far as risk assessment is concerned is participation. For any risk assessment to be effective, you must have participation. You must consult, you must have conversation with all stakeholders for any risk assessment to be effective. So often we confuse risk-based approaches to conventional public health, but it's important to differentiate risk-based approaches from what we traditionally known as public health, because risk-based approaches looks at risks and not hazards, as you know. Hazards are actually what can actually cause harm, but risks is a chance. It may be low or high. Again, the other difference, risk-based approaches looks at pathways as well as products. The other important difference is that risk-based approaches are solution focused. They focus more on how can we deal with the various risks that are involved, and it's not problem-oriented. So what I would like to do in the next few slides is really to give you a very quick overview of a project that we got together collaboratively between KEMRI, Ohio State University, University of Nairobi, and University of Florida. That is, and the purpose of really sharing the preview, a quick preview of this, is really for it to serve as an example of how you can do risk assessment as well as risk communication, the two key components of risk analysis. So the title of this study, which is, again, as I've said, is a collaboration between these key institutions and others, is Chakula Salama. So Chakula Salama is a Kiswahili name from Kenya or East Africa. That means safe food. So which is a risk-based approach to reducing foodborne diseases and increasing production of safe foods in Kenya. So the overarching goal of this project is to improve food security and nutrition in Kenya by developing capacity for system-based, risk-informed approaches to food safety that reduce risks of foodborne diseases, increase production of safe food, and improve economic outcomes. So specifically, we will be seeking to identify, in collaboration with the stakeholders, again, talking with stakeholders, food safety priorities for poultry value chains in Kenya using a risk-informed approach. Secondly, we will also be characterizing two pathogens, Salmonella as well as Campylobacter, in poultry value chains managed by mainly women and youth. Thirdly, we'll be developing and evaluating the efficacy of culturally and gender appropriate, practical, and scalable interventions for mitigating the risks of Salmonella and Campylobacter. Then finally, we hope to estimate the public health impact and evaluate the benefits and costs from selected intervention strategies to inform public and private decision making. What do we anticipate? What is our anticipated impact for this project? So we anticipate that at the implementation of this project, we will improve health in Kenya by developing a risk-based roadmap for making decisions and allocating food safety resources in Kenya that can be extended or scaled up to other value chains, pathogens, and all countries. Secondly, we anticipate that increasing this will increase the data that we will get will increase in-country resources for implementing such an approach. Because there will be buy-in from other people who are stakeholders who are like to support. We also expect that this project will also be able to advance the objectives in Kenya's 2013 National Food Safety Policy, which includes capacity building for laboratories and in risk analysis, because we have some students being trained on food safety. Concluding, so risk analysis is a key tool for decision making. An effective, in my perspective, an effective risk analysis approach requires the following. It requires scientific advice and information analysis, like what we are anticipating to do in the project that I've just given you a summary. An effective risk analysis approach must also have regulation and control. Talk about rules, regulations, and so on. Finally, an effective risk analysis approach, in my perspective, requires a dialogue, conversation with all the stakeholders. It must be participatory. I'd like to acknowledge KEMRI, Kenya Medical Research Institute, where I work, as well as the NI, Purgatory Global Health Training Program, which supported my postdoctoral studies, as well as the Global One Health Initiative and the University of Nairobi, with whom we collaborate in most of these projects. I thank you very much. Over to you, Bob.
Thank you very much, Robert. So great talks, all three of you. I invite our audience to please post questions in the Q&A box, and our speakers will be happy to answer those. In the meantime, while we're waiting for some initial questions, I wanted to, all three of you talked about low and middle income countries, and so and risk-based approaches, which are internationally recognized as the best way to manage food safety risks, given limited resources. So my question for all three of you is, what are the barriers to implementing risk-based approaches? What do you think are the most significant barriers to implementing risk-based approaches in low and middle income countries are?
Can I take that one?
Yes.
Thank you, Bob. So there are many challenges, but I'll name a few. Maybe my colleagues could add a few. So one of the challenges in low middle income countries is gender disparity. You find that women largely and as well as youth actually neglected as far as decision making is concerned in matters food safety, because they are not considered, for their decisions to carry weight. So this is one of the challenges. The other challenge, of course, is limited resources, because limited resources, then you are able, if there are more resources, then you are able to come up with more studies that can be able to give data that really can be very informative, that can encompass not only risk assessment, risk communication, but also risk management. So I think those are the two challenges that I can think of for now. I think I could leave my colleagues also maybe to add one or two. Over to you, Bob. Thank you.
If I can add, Barb, I think other underlying aspects are often weak regulatory systems. Even if regulatory systems would be improving, the food chains in many low and middle income countries are very distributed. There's a lot of, say, small vendors, small producers that directly sell. So the number of people that you have to reach educate in the basics of food safety is very big because of so many actors being involved. Also, I think lack of knowledge about basic principles of food safety and the challenge of reaching everybody involved in food production and distribution is also typical of many countries that have a lot of wet markets that have many small vendors.
From my aspect, when I provide some workshop or my feeling is that the lack of risk communication actually from the top to the bottom and also from the authorities to the consumers, there is a big gap there, and actually and also in education and also this training courses kind of fill the gap. But I think to interpret because knowledge there, I think the people, when I was there, I think people understand what I'm talking about. But how to translate that into a more practical work is totally something different. So I think the combination could really facilitate this kind of transfer of knowledge to the low and middle countries.
Okay, great. So we don't have any questions yet. I encourage all of our attendees to ask questions. But I wanted to ask a couple. Go ahead.
Maybe I answered one question already in the chat because I didn't have about artificial ingredients. It's somewhere in the. I think now in the answer part, which is something that is very, very common. One example that I'd like to mention where consumer, say, perception may lead to very uninformed usage, for example, uncured meats. We now know that cured meats, processed meats are classified as carcinogenic by IARC. And the underlying cause is nitrite that's being used to prevent, for example, the growth of Clostridium. That's also the reason why it's not easy to produce those cured meats without the nitrite. So when you now go to many supermarkets, you'll find uncured meats. And then when you look at the label, celery juice has been added. And there's a very good reason why celery juice has been added. That's because that provides nitrite. So for many consumers, the fact that celery juice is a naturally occurring product makes look safer. It's actually not safer at all. It still does the same job through the same chemical mechanism. So the myth that many consumers have that natural is safer, I think needs to be debunked. I'm not saying that everything that is synthetic by the definition is safe. There needs to be a very close watching it, and the framework needs to be evolving. But consumer perception that natural is safer is certainly not true in the area of food safety.
Yes, I agree. Robert, or is it Kane? Would you like to add to that?
Yeah. Actually, when I saw the questions, I was wondering, because my background is in microbiology, so I was thinking maybe some artificial agent is making the food safe because they kind of inhibit the growth of the pathogens or even kill them. So I think here it's not the problem with artificial agents or chemicals, it's the misuse of them will be a really unsafe step to do this kind of thing. So I think the question should be whether misuse or something like that will make the food unsafe. But I think artificial, if you use it appropriately, then artificial agent is not that a danger or something like that.
Right. And then, Robert, do you have anything to add? Because I think and you mentioned this, I mean, in low and middle income countries in particular, how do we communicate those risks to the population? And, this is a global phenomenon that some people feel that, natural is safer, but it gets down to the point of how do we adequately inform consumers about the trade-offs and risks and benefits for different foods that they consume and different methods of preventing contamination.
Thank you very much, Bob. So the challenge, I see that in many practitioners of food safety is a complaint that normally comes up is the language that is used in communication. Often we are accused as people who research in food safety as using a language that is not able to be consumed by the stakeholders. So we need to, what we've been suggesting is that we need to work with communicators, for example, journalists, who then can package a message, the data that we got, then it can have a broader reach. I think that's the challenge, and that's sort of the solution that I see to it. Over.
Great. And of course, risk communication and engaging journalists is always a challenge. But one thing I wanted to, and I know we have about 5 more minutes, and we have a very quiet audience this morning with not very many questions. But one of the things I wanted to return to is Ari had mentioned, presented on the first ever global burden of disease estimates, and mentioned that WHO is now starting to gear up to do a second version of those estimates. And I think one of the important things, those global burden of disease estimates have really gained a lot of attention because it showed that the burden of foodborne disease is on par with malaria and tuberculosis. And if you look at the amount of resources we spend on preventing those diseases compared to what we've historically done on food safety, it's pretty significant. So as they begin those thinking about those new burden of disease estimates and thinking about risk-based approaches, what would be your recommendation to the future burden of disease working group, if you had to make a recommendation? And how do we fill some of the data gaps? Particularly, I'm thinking about how do we fill some of the data gaps we've had historically. I mean, the estimates are really great, but there's some uncertainty in them, and how would we go about doing that?
That's a good question, Barb. One thing I think that is really imminent is expand the collaboration with countries. As I said, the first WHO estimates were only published on a sub-regional basis because they were not cleared by the WHO member states. That's a major hurdle to get used by countries, and you know how many efforts we are doing. For example, in Ethiopia, we're doing similar work in Burkina Faso and in Rwanda at the moment, working with the governments. And that's one reason why countries need to be more actively involved. The second, of course, is that many countries have data that have not really been made available in accessible reports, publications, or whatever. And also now has a manual about national burden of disease studies. My opinion is that the full the full study that they present there is beyond the reach of many, if not all, countries in the world. But countries will be able to look at this manual and see where can they contribute and where can they inform an international collaboration, so that building on the strength of many, we can arrive at better estimates, because obviously one of the limitations of the previous exercise was that we only used published data, be they peer-reviewed papers, be they grey literature. There was a major attempt in all the meta-analysis that was done to also access grey literature, but it's only those data that have been processed. So trying to create momentum in countries. China, for example, was a country where we had very little data, but there's a huge population. India is another example. So working with those highly populated countries and maybe set up task forces there that are looking at what data do we have available and how can we process them in such a way that they become useful for these international estimates would be a great way to strengthen this. So again, a lot of capacity building. But under international coordination, because of, say, the sheer mountain that doing these studies implies. You cannot climb it alone, you have to climb it together.
Yes. Robert or Ken, would you like to, we have 2 minutes, and we actually have a question.
Yeah.
So do we want to allow the question, Kaylee? I believe you're muted.
Yoko, if you could please unmute yourself, you have permission to speak and ask your question. So we do have a question. We just need to unmute themselves.
Okay, Kaylee, in the meantime, can we, if Robert or Kang have any follow-up thoughts to Ari's comment? I know we need to finish up here in a minute.
Yeah, if I may, Bob?
Yes, Robert.
Thank you. So the other, I think going forward, what I could also recommend is that any efforts in food safety, including risk assessment, I think any efforts must have representation from human, animal, environment, as well as plant, because for long, and I think I also stand accused, as researchers, we've build kind of our own silos. You say, I'm a researcher in food safety, I'm a microbiologist, and so I've little to do with an environmentalist or a plant scientist. So then we've then propagated so that there's no there's no progress in whatever efforts that are being made. So going forward, any efforts, including development of efforts, risk assessment efforts, scientific studies. I think let's form consortiums of representation from all the key components of the One Health. Secondly, in terms of capacity building, yes, it's good, but I also just wish to add that can we also have an element of monitoring and evaluation, just to sort of see what's the progress of what we are recommending. Because often I've had experience whereby we train lab technologists on food safety, but then as soon as the training is over, then that's where it ends. So we are not sure whether this is being implemented back at where they came from. So there must be, components in any efforts of risk assessment in food safety. There must be elements of monitoring and evaluation. I think that will be all from me for now. Thank you. Over to you, Bob.
Thank you. Ken, do you have anything to add?
Yeah, I'd just like to echo Ariel's comments that the collaboration between countries is really important. So everyone should engage, like what we said, food safety is everyone's business for the Food Safety Day. So actually, I think that's a really important point.
Great, thank you. And I believe our time is up, but thank you all for participating in and for presenting and then participating in this discussion. Food safety is a really important topic and certainly has One Health aspects. It's often presented as one of the examples of where One Health approaches are really needed to address risks and prevent foodborne disease. So with that, I thank you all for your participation, and I'll turn it over to you, Kaylee.
Thanks once more, Dr. Kowalczyk, and to all our panelists. We will take a short break. So next up is our genomics and bioinformatics session. We'll take a 10-minute break. I will pull up our break timer, and we will see everyone back here at 10:15 Eastern Standard Time.